All right, welcome everybody to our Vaccine Center of Excellence education series. This is our second event. So yesterday's event took place with a British Columbia audience, and now we are doing one for Alberta pharmacists. So my name is Ajit Johal. I'm a BC pharmacist and co-founder of the not-for-profit organization Immunize.io. I'm joined by my colleague Mark Zhao, and we have orchestrated a national series of webinars to help you elevate your immunization practice. So I'm going to start off by discussing what exactly is the Pharmacy Vaccine Center of Excellence program. And a picture is worth 1,000 words. So this picture pretty much sums it up. It's often challenging for patients to access vaccinations. And a lot of times people say, talk to your pharmacist or go to your local pharmacy. But which pharmacies are really actually equipped to address patients' immunization needs comprehensively? So we are trying to identify pharmacy locations that are committed to best practice immunizations, in particular, matching them with workplace immunization programs, as well as employers who want to get their staff vaccinated against all recommended vaccinations. So what's this all about? We're building on the success of community pharmacy vaccination services. So pharmacies have really stepped up to deliver a lot of vaccinations over the past decade. And we want to build on that success, and we want to take it to the next level. Basically creating like a specialization for pharmacies looking to offer the full gambit of immunization services. Something similar, a model that we look at in the United States, is on designated psychiatric pharmacies. So if there's a psychiatrist who has a patient with particular needs, prescribing specific medications, they want to set them up with a board-certified psychiatric pharmacist dispensing long-acting injectables or clozapine that requires monitoring. They have a list of pharmacies that are specializing in that sort of area. So we want to develop the same thing, especially for patient-seeking organizations who want to refer their patients to get vaccinations. And we want to make sure there's pharmacies that are willing to address these immunization gaps. So what is the role of our not-for-profit organization, Immunize.io? So we've started in 2018, and our mission statement is taking our best shot at immunizing the world. So our focus is on vaccine education and awareness, and we want to facilitate access to vaccinations to partner pharmacy locations. So some of the things we do is we educate a lot of workplaces and HR departments. We have a lot of upcoming events where we're educating employers, benefit plans consultants, and other providers on the importance of covering vaccines for their staff and why it's important and why it's valuable to the workplace. And in doing so, we hope that they'll start to instill vaccination programs in their benefit plans or even on site. And we want to provide them pharmacy partners, and this is a national initiative. So we've got some programs in BC and the Yukon, as well as collaborations with organizations like Crosslinks Health Benefits, which is a consulting company that educates and works with a lot of workplaces. And in terms of resources, if you're interested in learning more about how to conduct a workplace vaccination clinic and specifically how the program works, then check out our free training course. It's a 3-module program, free of charge, on the Vaccine Center of Excellence program. So in terms of the Vaccine National Immunization Workshops, it's a series of 5 workshops, and it's basically centered around how to have vaccine conversations in your busy practice, some key immunization gaps to focus on, navigating your scope of practice, especially in the pharmacy sense, like what vaccines can you administer, what gaps can you address, and of course, workflow strategies from our pharmacy immunization experts, individuals who have developed and built a robust immunization practice and have a lot of experience in doing so. Here's our workshop schedule. Today we are in Alberta, and we've got 3 more sessions in Saskatchewan, Ontario, and the Atlantic provinces. If you're unable to attend your specific province, you're more than welcome to attend another province, but each session focuses from a local expert focusing on how to address gaps with their scope of practice. So it brings me the privilege to introduce our expert speaker, and that is Carleen Olekson from Alberta. She is a pharmacist, pharmacy owner, and she has built a very robust immunization practice. So not only does she work in frontline immunization practice, but she is a prolific educator, award winner, published individual who has taken her best practices to a national level in terms of how they impact patient care in numerous disease states. But as Carleen would agree, immunizations are certainly her wheelhouse, and she just does a lot of education and has a lot to say, and you'll definitely benefit from her experience. So without further ado, I will pass it to Carleen.
Thanks, Ajit. And thanks everyone for being here tonight. Many of you have probably spent a long day in the dispensary already, as have I. So just thank you for being here and for taking the time out to do some really good learning about how to really incorporate vaccinations into your practice and to protect your patients, which is really what it's all about. It's all about protecting patients, right? So here are my disclosures. I have received an honoraria for the program tonight, and I am a member of a few advisory boards, Pfizer, GSK, and AbbVie. I do a lot of speaking and educating and a lot of work in the CME world, and do receive honoraria for those types of events. The program disclosure, this program has received financial support from GSK, Merck, and Pfizer as well in the form of an educational grant, and we thank them for that. That allows us to spend this time with you in some really great education. As Ajit said, you can check out the vaccinecenterofexcellence.com for more information on the VCE program. You can also take the free 3-module program in order to receive your recognition of vaccine excellence. So make sure to check that out as well. So what are our learning objectives? The learning objectives are to appreciate the role of community pharmacies in providing vaccination services, to recognize that the scope of practice for pharmacists across the country is different, and we'll talk about what it is in Alberta, to evaluate any immunization gaps in your community, in your practice, and to discuss some operational strategies to optimize your immunization services. We're gonna make this really practical. I'm not going to spend a lot of time on the details of each vaccine because those are things that pharmacists know and things that you can look up. What I really want to do is share with you some of the things that I do in my own practice, how we incorporate immunizations, how we talk to patients about immunizations, and how to proactively encourage you to, be proactive and protect those patients in ways that I think they're missing right now. There's a big gap in healthcare. Nobody's really addressing it. And how can pharmacists really do that? So this is going to be as practical as possible. And I encourage you to, if you have questions, please type them into the chat. So if questions come up while I'm going through the information and talking, feel free to type them in the chat so we can get to them at the end of the program. So why is pharmacy important? Well, I mean, pharmacists are key in the immunization space. And just to give you an example, I mean, we all know this, we're all pharmacists, but we are key in providing seasonal influenza, and we do some routine immunizations as well. COVID-19, of course, I mean, jurisdictions can't do it without us, and also our recommended unfunded vaccinations. So we're going to talk about that today. I put up some stats here just to show for our Alberta pharmacists out there. Pharmacists are rock stars in providing vaccination. And take a look at this COVID data. I mean, pharmacists have provided 4.8 million doses of COVID vaccines, and Alberta Health Services have done 4 million. So we far outpaced them. And really, we would have been far higher if we would have had access to the vaccine, right away. Because you can see we've provided 76% of dose number 3 for COVID and 81% of dose number 4 for COVID. So the public really depends on pharmacists to provide vaccination. I mean, we are the most accessible. We're easy to talk to. We're easy to get to. We're easy to schedule with. And we provide such excellent care for our patients. So by far, I would say patients prefer to come to us than to be coming through, especially for COVID and flu vaccines, than to go through the public system. So we really are critical in providing protection individually and as a community and for public health. So how do I incorporate immunization into my own practice? So I'm going to talk about this as we kind of go through how I sort of do that, because there's lots of different ways that I put this right into my practice. So just a few examples to give you an idea, and I'll probably talk about it as we go along. But things like, when a patient comes in for one vaccine, we always assess all their vaccines, right? So incorporating into practice means that we take a look at the whole patient. So really important to do that. And one way we do that is when we're talking to a patient, we always take good documentation and notes as to what vaccines they've had, what vaccines they need, so that we have that as an ongoing record for our patients. So taking a look at the whole picture of the patient is really important. Just because they're presenting with one vaccine, don't forget about all the other vaccines that they are eligible for and should have to protect them, right? So I open up those conversations with patients. I don't wait for patients to come to me to ask questions about immunization. I talk to patients proactively about it. Certain patients with medical conditions, of course, immunocompromised patients, those patients are always prioritized, and we make sure that we cover off those patients when we talk to them again about their immunizations. So these patients, are easy to see. We know which drugs compromise our patients' immune systems. We know what medical conditions compromise our patients' immune systems. So we target those patients as well. I do also run a travel clinic. So when I have patients coming in for travel vaccinations, I always discuss other eligible immunizations that are non-travel related, but that the patient should have in order to protect them. I always make sure I have lots of tools and things that help me do that as well. And we'll talk about that as we go on. So what is the scope of practice? So in Alberta, just as a reminder, pharmacists can provide injection services, including vaccines, only to those age 5 and above. I know, like RXA, our professional association, has really done some work lobbying government to say, hey, there's this big gap in providing care for the community, and pharmacists are well set up and trained to be able to give shots to patients younger than 5 years old. So we may see that change in the future. Government's been very busy on the COVID front, and there's also a change of government going on, or at least a change of leadership going on right now. So we'll see where that ends up. But I do know that that's something that the association has worked on, because there's a gap when we have, say, a family come in for flu shots, but yet we can't vaccinate their younger patients, right, or their younger family members. So right now, it is still 5 and up. The only public vaccines that Alberta pharmacists can administer that are publicly funded at the pharmacy site are DTaP in pregnancy, and only in pregnancy, P23 or Pneumovax for those over the age of 65, and of course flu and COVID. So we're a little bit limited in our public scope of what we can provide with a publicly funded vaccine. Of course, many pharmacists in Alberta have additional prescribing authority, which is handy, because as far as Schedule II vaccines, right now all we have is a Pneumovax and Prevnar 13. Prevnar 13, though, is being replaced with Prevnar 20. So having additional prescribing authority, at least over half of Alberta pharmacists have prescribing authority, so that they can prescribe the rest of the vaccines, which are Schedule I in Alberta. So if you want to be able to prescribe certain vaccines, then you need to have Schedule I authority. So Shingrix is also Schedule II, which doesn't need a prescription. So any pharmacist can prescribe that. So we'll kind of go through it as we talk about the different vaccines, but it is within a pharmacist's authority to administer all the vaccines. And certainly the Schedule II ones like shingles vaccine and P23 can be provided. And then, like I say, all the other ones require Schedule I, or a relationship with a physician, like if you have an ongoing relationship with a physician, or you fax a physician for authorization if you don't have additional prescribing authority for some of those other vaccines. So let's talk about the immunization gap. There is a gap for unfunded immunizations. There seems to be, and I think this is a view that's sort of held by the public, that if the vaccine is funded by the government, then that must be the only vaccines that are important, right? They don't realize that there's this difference between vaccines that are funded because it's a choice that the province makes and vaccines that are unfunded, but still as important to get. It's just been a choice for the government not to fund it. So it's an education that we need to provide to our patients that, just because you've received all the vaccines that the government will fund for you doesn't mean that you are as protected as you should be from infectious disease. So there's definitely gaps there. And in Alberta, especially, there is no coverage for such critical vaccines such as Shingrix to prevent against shingles. Pneumococcal vaccinations, the conjugate vaccine is only publicly funded for a very small percentage of people. Enhanced influenza like high dose flu. Just recently now, as of last year, we're able to access it for our over 65 population. But if you were immunizing last year in Alberta, you know what a gong show that was. And I think it was right across the country. There just wasn't supply when we needed it. And unfortunately, our senior population was having to choose between a funded high dose or if they couldn't get it, do they wait for it or get a funded regular, standard dose, or do they seek out a vaccine for high dose that they pay for themselves? So it was a bit of a disaster as far as public health goes with that. So hopefully it rolls out a little bit better this year. Our adolescents as well, we can't forget them, and it's even easier in our adolescents and our children to think that they're getting all their vaccines through the school program and through the public health program, and yet there is again a gap there with HPV and meningitis B, and we're going to talk about those vaccines today. We see a real gap with HPV. Sometimes it's kids who've missed school on the days that they should get it. Sometimes the parents have declined and then they've changed their mind. Meningitis B as well is not a publicly funded vaccine, and yet there's a big gap in care with that vaccine that we're going to talk about and how important it is for our adolescents. So let's talk first about shingles vaccine. Again, I'm not going to spend a lot of detail on the vaccine itself and how you mix it up and how you give it and all that sort of thing and the schedule, because that's stuff that you probably already know. But I will review quickly what the NACI recommendations are, because it's really interesting when you look at this vaccine. NACI updated their recommendations in 2018 as soon as Shingrix was approved, because it was just so much of a better vaccine than what we had previously. Previous to that was Zostavax. It was a great vaccine. It was the only vaccine we had at the time, right? So some protection is better than no protection. That's my tagline for all vaccines. And good to remember for flu season when patients say, well, is a vaccine only going to protect me a little bit? And I always say some protection is better than no protection. And that's what I said with Zostavax as well. But then when Shingrix came out, of course, you've got a vaccine here that is so much more effective. It's over 90% effective even in our seniors above the age of 80, over 95% effective in our younger patients. So really important to get the key messaging out to patients that this is a brand new vaccine. You will see a lot of patients who had Zostavax, and at the time they were told it's a one and done and there's no boosters needed and this is all you need. And there's a lack of understanding from the public then that there actually is a new vaccine out and that they should be revaccinated with it. Okay, so it's not a booster, it's a brand new vaccine. So the NACI recommendation is they have a strong recommendation for anybody over the age of 50, they should be vaccinated. Absolutely, unless they're allergic to a component. I've given over 2,000 Shingrix doses and I still have yet to encounter a patient who's allergic to it, but still need to be screened for that. So everybody over the age of 50, absolutely. Everybody who's received Zostavax in the past, absolutely. Strong recommendation from NACI to revaccinate. Patients who've had shingles in the past, yes, should be vaccinated with Shingrix. And that's, again, a strong recommendation. So when you take a look at that, you'll get a lot of questions from patients about that. about these recommendations. So what about a patient who's had shingles? And we get this question all the time. Do we have to wait the year? NACI recommends a year. NACI has a conditional recommendation to wait a year after a patient has had a bout of shingles before we vaccinate. It's really based on the original, their original recommendation for Zostavax, and they kind of carried it over. Of note, ACIP in the US does not have this recommendation. They recommend giving Shingrix as soon as active shingles disease is over. So I always say use your discretion. Do you have to wait the year? Sometimes it's pretty tough to wait a year because a patient can have another case of shingles. So use some discretion there if the patient does want to be vaccinated. And again, in Alberta, it is Schedule 2. You don't need a prescription for it. You can go ahead and prescribe it and give it yourself. There is the expanded indication that is really important to note here. Just recently, Health Canada has expanded the indication for immunocompromised individuals. So really key to be able to target these patients and let them know their eligibility for Shingrix, because I think the messaging is pretty good out there with the public knowing that it's an over 50 vaccine, but really unknown from the public and even with healthcare professionals that 18 and above now, if they're immunocompromised due to medication or disease, they really need to receive this vaccine. And the indication says it's for patients who are or who will be immunocompromised or immunosuppressed. So it's really key to take a look at that Health Canada indication, because when do we want to vaccinate our patients who are going to be immunocompromised? It's before their immune system is compromised, right? Because they'll get the best, more robust response to the vaccine if we give it to them before their immune system is compromised. So really important to let those individuals know that they should be vaccinated prior to therapy. And don't assume that somebody else is going to bring it up with your patient, because they don't. I don't know how many patients I have with rheumatoid arthritis, inflammatory bowel disease, MS, lupus. They're being started on immunocompromising therapy, biologics, and nobody talked to them about vaccines, not even the specialists. So it's always missed. So these are patients that we need to make sure that we capture in our practice and be really proactive about it. So how do I talk about Shingrix vaccination with my patients? Well, I've kind of worked it in already. The proactive piece is just so critical, and I'll probably be a broken record about that. But patients don't know what they don't know, right? It's up to us to tell them what they don't know. The vast majority of patients really believe that they are up to date on all their vaccines when indeed they're really not. So it's up to us to let them know. So I'm really proactive. It's very easy for anybody to know that everybody over the age of 50 needs to have this vaccine. So I use a lot of tools. I use a lot of conversation. I revisit it a lot. So if I talk to a patient about the shingles vaccine last year at their flu shot, and they were like, oh, I'm not really sure, I'm thinking about it, I'm going to talk to them about it again when I see them. So I make sure that we keep having these conversations. And then I make sure that we target the over 50. And with our immunocompromised patients, again, it's something that I have to keep reminding my staff about, even because they sort of forget, because it's new. So I do things like run reports and take a look at patients who are on certain drugs and make sure that I've tagged their file to say, hey, have that conversation about the shingles vaccine with this patient. So again, it's being proactive about making sure that we address it with the patient so that they know. Because one of the saddest things for me is when a patient comes into the pharmacy with a prescription for valcyclovir because they have shingles and nobody told them that they could have been vaccinated. And those patients would do anything at that point to not have shingles, right? And then they're getting, we see it as pharmacists all the time. We see prescriptions for, then they're getting gabapentin, and they're getting pregabalin, and they're getting all the drugs because they're in so much pain, right? Not to mention all the complications that you can get from shingles ophthalmicus, and you can get cardiovascular and cerebrovascular complications. There's a lot of things there that we can be preventing. So again, being proactive is just really important, and use your tools and run those reports. Make sure you get those second doses in with your patients as well. I find with COVID, sometimes we have forgotten about, we have patients who's kind of lagged with their boosters, and we want to make sure that we catch those second boosters and that it's never too late to give that second dose. So sometimes we've phoned patients and they've said, oh, I didn't want to come get my second dose because I thought I had to start over again. And then it was going to be, more expensive because I had to pay for 2 doses. And we proactively call them and just let them know it's never too late. It's never too late to give the second dose. Even if it's been a year, even if it's been 2 years, come in and get that booster. So let's talk about pneumococcal disease. So this is an interesting area of vaccination. Again, really important. These vaccines are not necessarily covered for the majority of the population, and yet so important to provide protection. So there is some difference in the vaccines. There's a conjugate versus polysaccharide. There's two different types of vaccines there. So the polysaccharide vaccine, most pharmacists are fairly familiar with. That's Pneumovax or P23. It is publicly funded in Alberta for our over 65 population through the pharmacy. It is publicly funded for those under the age of 65 with certain medical conditions or immunocompromised. But they have to go through public health to be able to access that. Pharmacists can't administer that, the public supply to those patients. But it is important to identify them and to refer them into public health. And those patients will often be eligible publicly also for the conjugate vaccine. So there is a difference to the vaccines. I don't want to get too technical about it, but I mean, the polysaccharide vaccine is a little bit shorter lived. It has a immunity that sort of rapidly declines, but it does cover 23 strains, right? It's P23 or Pneumovax. So it has a broader range of coverage and works quite well for invasive pneumococcal disease. So really, really important vaccine. And then you've got the conjugate vaccines. Previously was just Prevnar 13, covering 13 pneumococcal strains. Prevnar 13 is now replaced with Prevnar 20, which is now, as I noticed, it was in the wholesaler. It is in McKesson. There's also a pneumococcal 15 vaccine as well, covering 15 strains of conjugate vaccine. So the take-home message really is like, which vaccine do you use? Well, you use both. You use both a conjugate vaccine and a polysaccharide vaccine, and depends on the patients, and the spacing depends on the type of the way that you give the vaccine. So the way I approach it with patients is all patients over the age of 50 should have a conjugate vaccine done. So if they are healthy and they have no immune system compromise, no medical conditions that would trigger needing a P23, I at minimum talk to them about getting the conjugate vaccine. So getting that conjugate vaccine on board, right now Prevnar 20 is the one that is available through the wholesaler. That's what you want to get on your patients on board with, right? So patients over 50 automatically, when I have the conversation about shingles, I have the conversation about pneumococcal disease. And then if the patients happen to be over 65, then I will also talk to them about the P23. Or if they're a smoker, that's another indication for P23 that is not covered by public health. So you can't send a smoker to public health to get P23, but NACI says you should be giving those patients P23. So again, that would be something that you would be doing in pharmacy, and that would be privately covered. If your patient is immunocompromised, of course, you can send them to public health to get both of those vaccines covered for them. What is the spacing? Ideally, you want to get that conjugate pneumococcal vaccine in first, and then you want to space 8 weeks to your P23. So I often time this up with a shingles vaccine for a lot of patients also. So when a patient is in for their first shingles vaccine, I will encourage them to get their first pneumococcal conjugate vaccine. So I'll be doing usually a Prevnar with them. And then 8 weeks later, we will do their second shingles vaccine. And if they're eligible or require the P23, we'll do it at that time, okay? Because their spacing works out nice and even. If a patient has, when I assess a patient for their pneumococcal vaccine status, and I take a look at their vaccine records, and of course in Alberta we're quite lucky that we can pull public health records right away off of Netcare. So we take a look at that. If you see your patient is say over 65 and has received P23, or they're immunocompromised, so you see a P23 that they had there at public health, but nobody has talked to them about a conjugate vaccine, then you just need 1 year spacing. So if you do them the other way, you need a year. If their P23 is had, just make sure there's a year, and then encourage them to have that conjugate vaccine, which is also really important to prevent pneumococcal disease. So how do I talk to patients about this? And again, I kind of worked it into the last slide, but I make sure that I proactively talk to all patients about it. I use my pamphlets a lot. All patients over 50, I'm handing them pneumococcal disease pamphlets and about the vaccine. I also talk to a lot of patients when we're talking about COVID. I work in pneumococcal disease, right? Because pneumonia can be a complication of COVID, and certainly, really important to be able to protect those patients. And our infectious disease specialists will tell you, like, can we please get as many patients vaccinated against pneumococcal as possible? And so I have those conversations about pneumonia and invasive pneumococcal disease with patients who are concerned about COVID or who are coming in for their COVID shots, right? So again, taking every opportunity when the patient is in your chair to talk about all available vaccines for them. So I work that into in the same way that I would work in with shingles vaccine. I'm, targeting age, targeting patients with medical conditions, targeting them if they are coming in for other vaccines, and I'm going to talk to them about this one as well. So let's talk about HPV. It is recommended for both boys and girls. This is something that we should be really familiar with by now. It was, originally brought out for girls for cervical cancer, but now we know that it also is recommended for boys, and not just for genital cancers, but also indicated for the prevention of head and neck related cancers, because we have seen such good prevention for these types of cancers. So it is a cancer prevention vaccine, and that's a take-home message that we need to make sure that parents are hearing, is that it is a cancer prevention vaccine, because it is the lowest uptake of all publicly funded vaccines because it's related to sexual activity, right? But we really need to hammer home that really this is the one vaccine, other than hepatitis B, this is the one vaccine that really can prevent cancer. And what better public health intervention can we do than prevent a case of cancer, right? In talking about boys and girls, I just want to make the point that boys were lagging in the public system in Alberta as far as coverage goes. So when you're talking about the gap in care, like a lot of pharmacists don't address HPV vaccine because they think, well, kids get it in school, I don't need to really be involved, which is completely not true. When you take a look at boys as young as in their 20s missed out on public health HPV vaccine. So my oldest son is 22, and I vaccinated him myself because it wasn't publicly available yet when he was in school, right? So those 20-somethings did not get access to publicly funded vaccine, and still important to vaccinate them, right? So don't forget about those patients. A lot of them come into your pharmacy, and you need to be talking to them about this. I find that sometimes it's good to talk about sexually transmitted diseases in general. You can talk about genital warts with them. Sometimes that encourages our younger folks to vaccinate if they're not as concerned about cancer at a young age. But definitely don't forget about that population. The other thing that's really important to note is that a lot of our patients in school got HPV-4 vaccine. And you can see that on Netcare. You can see which HPV vaccine a patient got. If they got HPV-4, then it's important to have a proactive conversation with those patients to say, hey, you know what, you were vaccinated with HPV-4, but there's a new vaccine out now, HPV-9, that's Gardasil 9, that will protect you from those extra strains. And I do a lot of that. I do a lot of vaccinating with Gardasil 9 for patients who had Gardasil 4 because they want that extra protection. So you can do that. There's no problem at all in revaccinating patients to get that extra strain coverage. So have those conversations. Keep in mind that there is really no upper age limit. And that's according to NACI as well. So we know that, the monograph says age 9 to 26. But really, if anybody is going to have any further sexual partners in their life, then this vaccine would be indicated for them, of course. So a lot of people, who are, getting divorced in their later years, these are patients that we also need to be talking to about HPV vaccine, because not everybody will be immune to it just because of age. So have those conversations with those patients as well, and be really proactive about it. So again, how do I talk to my patients? These are the patient groups that I target. I take a look at anybody sort of like age 20-ish and up. Although I do take a look at some of my older teens who only had HPV-4. And then make sure that they're offered HPV-9. There's a lot of patients who have private coverage that this would be covered for them. And the other thing I always do with not publicly funded vaccines that I'm encouraging with my patients, I always offer to check their insurance for them. Like, let me just see if it's covered for you. And you're sitting here in my chair. If you have your insurance with you, let me just take a look at it. Let me see if the vaccines are covered, and let's give it. And I do that with all vaccines. And it makes it very easy for them if you can just tell them, hey, you know what, this is only going to cost you, $15, or this is 100% covered for you. Why don't I just give you the vaccine right now? and you'll get a lot bigger uptake on your vaccines. So again, don't forget about your boys, don't forget about that older population as well, and don't forget about those who've only had HPV-4 and could benefit from HPV-9. Meningitis B, this might be something that pharmacists are a little bit less familiar with, but so important. So, the burden of disease for meningitis is huge, right? And sometimes what happens is we'll see a case of meningitis crop up in a school, a university, or a hockey team or something like that. And, the first person who acquires Men B, they're the ones who have the severe consequences, whether it's, neurological damage, brain damage, or even dying from it. And then there's this mass vaccination campaign, around them and in that community so that it doesn't spread. But how sad for the person who has the initial case. So really being proactively to prevent Men B is so important. And again, this is a lack of knowledge in the community. It's a lack of knowledge in healthcare providers that our kids do get in grade 8, 9, they'll get a meningitis vaccine, but it's Men ACYW, so it doesn't contain the serogroup B. It's not in there. And so what we're finding now is when we see a case of meningitis coming up in a community, that very often it's meningitis B because there has not been vaccine protection for it. So there is a vaccine out there. It's called Trememba. It is indicated for those who are age 10 and up. So this is a vaccine that you can order and bring into your pharmacies. Again, I like to focus on high risk groups. So I will focus on, even though it's age 10 and up, I usually will focus again on kids who play sports, kids, even high school kids, really important. I talk a lot to post-secondary students about it. I know those who are going into universities, into dorms, those who are traveling and, could be in close quarters with a lot of young people. So all of those populations, I make sure that I talk to them about meningitis B. It's a 2-dose vaccine, easy to give, and will provide you with some protection against that missing serotype. So make sure that you do proactively talk to those patients. And again, when I have young girls coming in for birth control, I have, boys who come in for various things. And anyone who's going back to school, we often do back to school like vaccinations. We will do vaccine assessments for requirements for programs. Like we see people going into nursing programs or into healthcare professional programs where, they're required to have all these vaccines, but this is never one of them. And I always make sure that we talk about it to make sure that they've got their meningitis. And you'll see young people coming in for their COVID shots, their flu shots. And again, this is a pamphlet that I always give out, and I always talk to parents about it as well. And I'll say, this is just something the government doesn't fund, but that is so important. I tell them that I've given it to my own kids. I have 3 boys and I vaccinated them and how important it is. So make sure you work it into those conversations with all those high risk patient populations. So how do I incorporate and prioritize immunization in my pharmacy practice? So I did talk about a few things already, like using your tools is really, really important. So one other thing is to use your people. So use your team so that it's not all on you. Use your team, talk about vaccination with your assistants, with your technicians, talk about who is eligible for it, who are we trying to target, how can we do that, and get them involved. Revisit it with your patients is another thing that is really, really important as far as prioritizing immunization. So in my pharmacy software system, for each patient, I have a vaccine tab or vaccine note. And in there, at some point, we have listed the vaccines that the patient should have due to their age, their medical conditions, et cetera. So we'll list all the vaccines. And then we'll have a note beside it whether where they're at with it, either they've received it, and we put the date, or we've discussed it on such and such a date, they're considering it, they've declined it, whatever it is, so that now when my patients are returning month after month or year after year for other vaccines or for medications, I can just have a quick look. Oh, Mrs. Smith, I see she's Shingrix. Oh, we completed her Shingrix last year. Pneumococcal, she has not yet had that. Let's talk about that again, right? DTaP, which we didn't talk about in the program, but DTaP, have they had it in the last 10 years? So we make make a list of all their vaccines, and you only have to do it once, and you just keep updating it like you would your drug file. So we do that so that we can revisit with the patient and we don't have to start the conversation over again, and it just saves some time. So when Mrs. Smith comes in for her flu shot again, we know that, oh yeah, we talked about the shingles vaccine last year. She was thinking about it, so let's talk to her about it again. And what I'm finding post-COVID is that patients know a lot more about vaccines than they used to. They know a lot more about infectious disease. They are a little more, like I find patients who declined vaccines previously are now calling us back and saying, hey, you know what, I want that vaccine now. So it's a very interesting shift in the public. I also use systems to make sure that we are capturing patients. So, one thing is to use your consent forms, and this is something I think pharmacists are pretty good at. Having the questions on the consent form for patients, have you received the shingles shot in the past? Have you received pneumococcal vaccination? And just asking those questions. And sometimes patients have no idea, but it stimulates the conversation to have with the patient, right? And also, it also will tweak other clinicians in your practice to make sure that they are systematically checking the vaccines for all of those patients at the same time, right? So that everybody's sort of on the same page and working on it. One thing to keep in mind when a patient says, yes, I've had the shingles vaccine in the past, is to always check which one they had, because again, if they had Zostavax, they should be re-immunized with Shingrix, and sometimes that can get missed by just having it checked off on your consent form. The other thing is just using language that is presumptive and has conviction. So if you believe in vaccines and you believe how important they are to protect your patient, then you convey that to your patient, right? I strongly recommend vaccine. I strongly recommend this to you. I vaccinate my family. I've given this vaccine to my spouse. And anything that you can do to instill confidence in the patient is just so important. What challenges have I faced? I would say one of the main challenges sometimes can be staff, especially when a new staff member comes in. So that can take a little bit of time to get them sort of up to speed on how we prioritize vaccines in our practice and what the systems are to make sure that we capture patients who are eligible for vaccines. So staff can be a challenge as you train that. And if you're starting kind of from scratch with this, training your staff is going to be something that you have to do, because it really is a team effort, right? So having systems in place, and really with COVID, systems sometimes are just changing a lot, right? Because we're having to change who we're talking to and what ways we're talking to them. And at first we're spacing COVID vaccines and now we're not. So, and again, that's an important point to make too, is that if you don't know that already, although, we've been doing this for a long time in Alberta, make sure that you do know that you can give a COVID vaccine with any other vaccine. So NACI, of course, recommends that you give every vaccine possible to the patient who's sitting in front of you in your chair, because they may never return. And we certainly had with COVID vaccines, especially those first two that were needed for the exemption program. I had some patients come in and those are the only vaccines they've had since they were a baby, so it's a real opportunity with those patients in your chair to be able to educate them. So make sure you have good systems in place and that everybody is following the systems. And then probably the other barrier, and lots of pharmacists would say this, is time, right? So how do you do it when you're pushed for time? And again, I always say, go back to your tools, have things readily available, right? At each of my intake stations, I have the pamphlets that I want to be able to talk to patients about the vaccine, right? I can throw them into the baskets, I can hand it to the patient. So I have those tools readily available. So I want to have the verbal conversation and proactively approach them, but I want to give them something to take home. So I always make sure that I have tools available. I make sure that I use my staff. So, I'm not the one who's always having to create the facts to the doctor, send the facts to the doctor, saying that I gave a vaccine, or, I've trained my staff on how to use IDSM, because I have a trusted technician that I'm like, here, you're going to enter all these vaccines into IDSM, and they can do that for me, because it really, the technical things do not have to be done by the pharmacist, right? Use your staff so that you can focus on the clinical and focus on talking to the patients and getting the message out and getting those patients to come on board with the protection that they need. So just make sure that you use your time and your staff to free you up to do what you're supposed to be, or what you should be doing as a clinician. So those are some of the challenges I've had, and how I've sort of worked through some of them to have a more robust immunization practice. So parting words of wisdom. Well, I would say, I've said this a lot. I told you I'd be a broken record about it. Be proactive. Patients don't know what they don't know. You have to tell them what they should be having and what the disease burden is, right? And how these infectious diseases can affect their quality of life, right? And use stories to do that if you need to. And we all know patients who have suffered from pneumonia and patients who have suffered, from shingles. We see it all the time in our practice, and get that out there and be proactive about it. I'm sure some of us even know patients who've been through HPV-related cancer and how devastating that is in their life. So be proactive and talk to those patients, because you may be the only healthcare professional who does that. You might be the difference between someone who suffers from that infectious disease and someone who doesn't, because you took the time to have that discussion with the patient, right? Be ready. So have your tools there, have all the information that you need readily available, so you don't have to scramble for them. You don't have to scramble to kind of find the pamphlet or find the information you want or make that recommendation, right? Make sure that you have a system in place as to where you're going to document patients' vaccine history so that you can have those conversations. And again, involve your team, talk to your team, make sure that it is a priority for everyone. So it's not just on you as a clinician to prioritize immunizations in your practice and protect your patients. So I'm going to leave it open for questions now. If you guys want to type any questions that you have into the chat, then I'm happy to take any questions at all. Questions about practice, questions about the immunizations themselves, any kind of burning questions you might have about vaccines. Happy to answer them.
Well, first of all, thanks, Colleen, for such a wonderful, well-rounded presentation. I like how you made it so personal, and also your workflow tips will certainly be invaluable in terms of optimizing what pharmacists can do. As Carly mentioned, please put all questions in the chat. There is a question here from an attendee about Shingrix or shingles. In terms of Shingrix, is there any updated information about how long the protection lasts? I tell my patients that it should protect for at least 5 years, but possibly longer.
Right. Yeah. So I should in the presentation. But so right now, what they do is they're following the original Zoe trials for Shingrix are up to, I think, about 8 years, and it's showing very robust immune response still. So and then there's modeling data that is showing that probably you're going to have a really good retention of their immune protection for up to 20 years. So that's what I tell patients is I say that, we have data till about 8 years. That's looking really good, very little decline in protection, and modeling shows up to 20 years. And patients kind of know what modeling means now because they've kind of been through the whole COVID roller coaster with that. So I always tell them it's a very long lasting vaccine. They're likely not going to need any boosters. There's no indication for that right now. I make sure that they know how effective it is. Also, because it's such a long lasting, or looks like such a long lasting vaccine, that they shouldn't wait to get it, because that was one thing with Zostavax is sometimes physicians would indicate to patients, well, maybe wait till you're a little older, maybe wait till you're 60. And I always say, don't wait. There's no point in waiting, because the burden of disease is so high and can really affect your quality of life. So I always let patients know that it's quite a long-lasting vaccine.
Perfect. Well, thanks for that, Carleen. And then the other question is a clarification on the scheduling of Shingrix in Alberta. So attendee asks, I will also want to clarify the scheduling of Shingrix in Alberta. NAPRA still shows it as Schedule 1. ACP's document about exceptions to national drug schedules doesn't list the shingles vaccine, suggesting that it should still be Schedule 1. Was there a recent change to this?
Yeah, so nationally, Shingrix was changed to Schedule 2, actually. And so provinces can't take a Schedule 1 product and make it a Schedule 2 product. They can't make it less stringent. They can only go the other way. So they can only take a Schedule 2 project and say Schedule 2 item and say, no, it's now going to be a Schedule 1. So they can make it they can make a stronger scheduling for it. So they can't go the other way. And yet you're right, it's not in the the Alberta schedule as showing that it should be Schedule 1, as other vaccines are. So it is nationally a Schedule 2 vaccine. And that happened, I don't know, I think, was it a few months ago, Ajit, I think? I can't remember exactly, but.
Yeah, it did happen a few months ago. So obviously in BC, the province moved everything to Schedule 2 for all vaccines based on any national and international guidelines. So that was a redundant change for BC, but in Ontario, moving it to Schedule 2 had a significant impact, and then in Alberta too, as well.
Yeah. Yeah, and Alberta did not choose to put it back to Schedule 1. They were following the national guidelines on it.
So it is nationally, it is a Schedule 2 product.
Mm-hmm. Yeah.
Okay. Well, thank you for clarifying that. I also had a question about, you mentioned in Alberta, there's limited access to publicly funded vaccines. And you had such a good discussion about the HPV vaccine, it being a cancer prevention vaccine, knowing where the gaps are. Do you think it would enhance your immunization practice? Because you talked earlier about the whole family immunization scenario where you can't immunize based on age. But would you be like supported in your practice to do have more discussions about HPV vaccination and possibly increase rates of HPV vaccination if you had access to publicly funded HPV vaccination?
Yeah, absolutely. I think anytime we can move a vaccine out of public health and into the pharmacies, you're going to have a much better uptake. I find that with the HPV vaccine, sometimes it requires a one-on-one conversation with the parents, and they're not getting that by having it only received through schools for their children. I also have a lot of my patients, children who are just more comfortable coming to the pharmacy. They don't want to receive a vaccine with all of their friends in school. And so I do a lot of them privately that way for patients who have private coverage, but I know there's a lot more who would want to come to receive the vaccine in the community from their pharmacist who they know, if it was publicly available. So absolutely. And I also think that we'd be filling a lot of gaps. If it was publicly funded for patients, say, who had HPV-4 and now they could get HPV-9, like that would be amazing, because we just, that whole population could just get that more robust protection, as well as we could catch some of our older individuals. We're only catching our kids right now, right? So catching some of those older and individuals who never had the opportunity to be vaccinated against HPV. So absolutely, anytime we move a vaccine into the community space, you're going to get a much better, stronger uptake on vaccination.
I agree, and hopefully there will be some changes in Alberta to allow this to happen. I know in BC we can access it. There is a bit of a workaround, but it's not restricted. So it does help to be able to vaccinate those individuals, like you said, who may have just missed it. Like they literally just did not go to school that day for whatever reason. So they're not opting out or anything. So we've had a few cases of that. And sometimes they are a little bit older too, so they will need 3 doses instead of 2. Yeah. So I think it's just such an important movement of vaccines into a place where people can have access. So yeah, sure. That's a question I wanted to ask. The other question I had was regarding meningitis B. You mentioned like in Alberta, it's only publicly funded. They'll only roll it out in an outbreak, because that was the question we had yesterday in BC was, when is MenB, is it covered? And the answer is no, but if there's an outbreak, they will dole it out in theory.
Yeah, that's the same in Alberta. There's no public funding right now for meningitis B. It is only available privately. And not only that, but a lot of parents just don't even know about it, right? Which is a real shame. We really have to get the message out there to parents that this is important protection for their kids. So there is no public funding unless there's an outbreak situation. Okay,
yeah, good to know. At this point, we don't have any additional questions. If there are any questions, please type it into the chat. But I think on behalf of Mark and myself and all the attendees, we really appreciate you taking the time to really make this practical, personal, and really allow these messages to resonate to pharmacists. I feel like I can start a vaccination practice in Alberta. I feel like I know all the gaps and what's publicly funded. So thank you so much for your time and expertise. We really appreciate it.
Yeah, you're very welcome.
Perfect. So as mentioned, this session is recorded for those who are unable to make it, and we'll be posting it shortly. But thank you, Carlene, for your time, and thank you to all of you for attending today's session.
All right. Thanks, Ajit. Have a good night.